Welcome to another deep dive. Today we're digging into, well, a really intricate and often misunderstood world mental health crisis and intervention.
That's right. We're talking about understanding a whole spectrum of conditions.
Exactly, from the intense ups and downs of mood disorders to the deep impact of trauma and that really complex challenge of substance use.
And crucially, we'll look at the interventions and support systems that are actually out there to help people through these really tough journeys.
Okay, let's unpack this. Today we're taking a deep dive into what can feel like an incredibly dense and often misunderstood area, mental health, crisis, and intervention.
Yeah, and our mission really is to go beyond just scratching the surface. We want to cut through some of the noise, pull out those key nuggets of knowledge that might shift your perspective a bit.
Challenge assumptions, maybe?
Definitely challenge assumptions, offer some real clarity. We're aiming to connect the dots, between these different conditions and see how they play out in the real world.
And so the goal isn't to overwhelm you listening.
Not at all. It's about empowering you with understanding, helping you feel truly well-informed.
Absolutely. So let's start by kind of mapping out this landscape of mental health conditions.
Yeah.
I think what's really vital to get right from the start is how connected these conditions often are.
It's not like they exist in separate boxes.
Right. It's actually pretty common to see overlapping symptoms or, find that interventions that work for one thing might help with others too.
Exactly. So today we're going to explore three big categories that are often linked.
Okay, what are they?
Mood disorders, trauma and stressor-related conditions, and substance use disorders.
That makes sense. It's a common misconception, isn't it, that these things are totally separate?
It really is. But when you think about the brain, how incredibly interconnected everything is, it makes sense that they'd influence each other.
Yeah, understanding those links isn't just academic, is it? It actually helps us see why, holistic care is so important.
Precisely. Which is a great lead-in to our first big category, the mood disorders. We'll focus specifically on bipolar disorder and major depressive disorder.
Okay, terms we hear a lot, but maybe don't always grasp the full picture of. Where's the line between just having a bad day or feeling moody and a clinical disorder?
That's a fundamental question. And with bipolar disorders, the core thing, the defining feature, is these dramatic, often really debilitating swings between emotional highs, mania or hypomania, and profound lows, which are major depressive episodes.
So like a seesaw gone wild.
Kind of, yeah. But driven by really complex shifts in brain chemistry and, life experiences. It's that persistent, disruptive up and down swing that really defines it.
And it's not just one thing, right? Bipolar isn't monolithic.
No, absolutely not. There are three main types, each with its own flavor, its own challenges.
Okay, let's break those down. I think understanding the differences is probably key for diagnosis and getting the right help. So, first up is bipolar I disorder. This is often seen as the most severe type, isn't it? And it's defined by having at least one full-blown manic episode.
Right. And when we say manic episode, we're not just talking about being really energetic or excited.
No, it's much more intense. It's this overwhelming state. People might have boundless energy, but critically, their judgment is often severely impaired.
Yeah. You see things like impulsive spending sprees, really reckless behavior, hypersexuality, sometimes even hyper-religiosity.
And delusions, too. Like believing they have special powers.
Exactly. Grandiose delusions are common, believing they're a deity or a famous person, completely detached from reality. It can also present as very agitated, even aggressive or violent sometimes.
Which sounds like a safety concern.
A huge one. People in a full manic state might be so hyperactive they don't eat or sleep for days. That leads to serious physical problems. Dehydration, exhaustion.
And their thinking gets jumbled.
Very much so. Pressured speech is common, talking so fast you can't keep up. Or loose associations, jumping between unrelated ideas, maybe even clang associations, where they rhyme words randomly.
Wow. So that lack of impulse control and the distorted reality, it makes sense that bipolar has a high mortality rate. You mentioned suicide risk.
Tragically, yes. The risk is high during both manic and depressive phases, and bipolar I affects men and women pretty much equally.
And that full manic state you described, it sounds like a real psychiatric emergency.
It absolutely is. The potential for immediate danger to themselves or others is incredibly high because of that poor judgment and impulsivity. Getting help quickly is just crucial.
Okay, so that's bipolar 1. What about bipolar 2 disorder?
So bipolar 2 requires at least one hypomanic episode and at least one major depressive episode.
Hypomanic, so like mania light.
Kind of, yeah. It's a less dramatic, lower-level mania. The person still has excessive energy, maybe feels euphoric, but, and this is key, they often have increased functioning.
Increased functioning, how does
Yeah.
that work?
Because of hyperfocus and maybe heightened productivity, they're energetic, definitely on, but typically without the full psychosis or severe impairment you see in bipolar 1.
So that could actually make it harder to spot, couldn't it, if they just seem super productive?
Exactly. It can be misleading. Bipolar 2 is often harder to diagnose initially because that hypomanic phase might just look like a really good creative period.
So it's the lows, the depressive episodes that usually make people seek help.
Very often, yes. Because the depressive episodes in bipolar 2 can be just as debilitating as in major depressive disorder. And interestingly, bipolar 2 is diagnosed more often in females.
That subtlety about functionality and hypomania is really important. It could mask the disorder for years.
It really can. Okay, then the third type is cyclothymia or cyclothymic disorder.
And this is the least severe.
In terms of symptom intensity, yes. But least severe doesn't mean it's not disruptive. It's characterized by alternating periods of hypomania, those milder functional ups, with mild to moderate depressive symptoms.
So not full major depression.
Right. And for a diagnosis, these back and forth symptoms need to have been going on for at least 2 years. They experience significant mood disruption, but it doesn't hit the full criteria for mania or major depression like in bipolar 1 or 2.
Got it. And you mentioned something called rapid cycling.
Yes, and this can happen in any of the 3 types. It's not a separate diagnosis, but a specifier, kind of like an add-on description.
Okay, what does it mean?
It means someone experiences 4 or more distinct mood episodes, depression, mania, or hypomania within a single 12-month period.
4 or more.
Yeah, and these shifts can happen incredibly fast, like within weeks, days, or sometimes even within 24 hours. It can be really abrupt and destabilizing.
That sounds exhausting. And you mentioned brain structures earlier.
Right. Research often points to differences, maybe abnormalities in specific areas. The prefrontal cortex, that's like the brain's CEO, handling planning, judgment, impulse control.
All things affected in bipolar episodes.
Exactly. And also the amygdala, which is deep in the brain and heavily involved in processing emotions, especially fear and pleasure. These biological findings really highlight that it's not just
It
psychological.
really helps ground it in biology.
Eh.
Okay, let's shift now to major depressive disorder, MDD, the pervasive low.
Yeah, and this isn't just feeling blue. MDD is a leading cause of disability worldwide, actually. It really impacts people's ability to function.
How is it defined clinically?
It's characterized by that persistent feeling of sadness or emptiness or sometimes irritability that just colors everything.
And for a diagnosis.
You need 5 or more specific symptoms during the same 2-week period. And critically, one of those symptoms has to be either persistently depressed mood or what we call anhedonia. That's a significant loss of interest or pleasure in pretty much all activities you used to enjoy. It just sucks the joy out of everything.
That sounds awful. What are the other symptoms?
Things like major changes in weight or appetite, sleep problems, either insomnia or sleeping way too much, hypersomnia, pervasive fatigue or lack of energy, we call that anergia,
Okay.
feelings of worthlessness or excessive guilt, trouble concentrating or making decisions, and then, really importantly, recurrent thoughts of death or suicide.
And those last two, worthlessness and thoughts of death, those are huge red flags, aren't they?
Absolutely critical red flags. They signal potential suicidal thinking, and everyone, healthcare pro or friend, needs to be aware of them.
And if you are talking to someone who's deeply depressed, how should you approach it?
It's important to use simple, concrete words. Give them plenty of time to respond. Listen really carefully, not just to the words, but for, hidden meanings.
Like what?
Like someone saying, oh, don't worry about me, I'll be fine tomorrow, which might actually be a kind of farewell.
And things not to say?
Definitely avoid platitudes. Things like cheer up or look on the bright side. They just invalidate the person's pain.
So what can you say, especially if they're quiet?
Sometimes just making an observation that shows you see their struggle is better than asking a direct question. Like, it seems like you're having a really hard time today, rather than demanding, why are you so quiet?
That makes sense.
Yeah.
Okay, moving from mood disorders, let's talk about trauma, stressor-related, and dissociative disorders.
Right. These conditions really show how the brain tries to cope with overwhelming experiences, sometimes in ways that change how people see themselves and the world.
And the first one many people think of with trauma is post-traumatic stress disorder, PTSD, that lingering echo of a deeply distressing event.
Yeah, and the classic symptoms are really disruptive. People often struggle with recurring nightmares, night terrors, and vivid flashbacks.
Flashbacks aren't just memories, right?
No, they're terrifying episodes where the person feels like they're reliving the trauma right here, right now, with all the sights, sounds, and intense fear. Intrusive thoughts about the trauma just pop into their head. They often feel constantly on edge, hypervigilant, always scanning for danger, and they actively avoid anything, places, people, even thoughts that reminds them of the trauma.
And emotional numbing, too.
Yes, feeling detached from their own feelings or from others, just kind of shut down emotionally.
And with kids, PTSD can look different.
It can.
Mm.
You might see them reenacting the trauma in their play, maybe with dolls or drawings, in a repetitive way, or they might have disturbing drawings.
Is there a typical path to recovery?
Often, therapy follows a kind of three-stage model. First is safety and stabilization, helping the person feel safe and learn to manage overwhelming emotions.
Okay.
Second is symptom reduction and memory work. This is where therapies like EMDR or cognitive processing therapy come in to help process the traumatic memories safely.
And third?
Integration and reconnection, focusing on problem solving, rebuilding relationships, and getting back into life.
That sounds like a long road. Now, building on trauma's effects, you mentioned dissociative identity disorder, DID.
Yes, formerly known as multiple personality disorder. This involves a really profound splitting of realities within a person's consciousness. It's a complex adaptation to extreme stress.
It sounds almost unbelievable, but it's very real. What might a professional notice during an assessment?
Well, things like unexplained blackouts, big gaps in memory, finding clothes they don't remember buying, being called different names by people they don't recognize.
And risky behaviors.
Sometimes, yeah. Reports of risky or even criminal behavior done by alters or alternate identities that the main personality has no memory of.
And this is strongly linked to trauma.
Almost always. It's linked to severe, chronic, usually childhood trauma, often horrific abuse. It's seen as the mind's way of compartmentalizing unbearable experiences by creating distinct identities.
Right. These alters are distinct identity states, each with its own way of seeing the world, relating to others, thinking. But they're all fragmented parts of one person.
So the goal isn't to, get rid of the alters. Generally, the goal is integration, bringing these fragmented parts together into a more unified sense of self through long-term intensive therapy.
What does care look like?
A huge focus is on safety, reducing anxiety, and helping the person understand that these dissociative responses were actually survival mechanisms in horrific circumstances. Consistent, calm environments are key, avoiding overstimulation.
Okay. And you mentioned dissociation flashbacks. There's a practical tool for that, right? The 5-4-3-2-1 thing.
Yes. The 5-4-3-2-1 grounding strategy. It's fantastic for depersonalization, derealization, or flashbacks, those moments when you feel disconnected or overwhelmed.
How does it work again? It's about engaging the senses.
Exactly. It anchors you back to the present. You name 5 things you can see, 4 things you can hear, 3 things you can touch, 2 things you can smell, and 1 thing you can taste.
So simple, but powerful.
Yeah.
Imagine using that or suggesting it to someone to just interrupt that overwhelming feeling.
It really is a cornerstone technique. It gives people back a sense of control. Okay, let's shift gears now to substance use disorders, SUDs. This is an area where understanding has evolved a lot.
Yes, and here's where it gets really interesting, I think. It's so crucial to reframe addiction, isn't it? It's not a moral failing.
Absolutely not. It needs to be understood as a chronic medical condition, a complex brain disease.
Like diabetes or asthma.
Yeah.
Something managed, not just cured.
Precisely. That reframing is vital for treatment and also for fighting that awful stigma that still surrounds addiction. It fundamentally changes how the brain's reward system works.
How so?
Well, it hijacks areas involved in motivation, memory, all that circuitry. Over time, the brain adapts so much that it might only feel normal when the drug is present, driving this intense craving.
Right, which leads to that cycle of addiction. You can see it emotionally and biologically. Emotionally, it often starts with some kind of emotional pain, right?
Yeah. Trauma, stress, underlying mental health issues.
Which leads to a craving for relief.
Yeah.
So the person turns to substance use.
Which might offer temporary relief, but then come the negative consequences.
Legal troubles, relationship problems, health issues.
Exactly. Which then increases the original emotional pain, making the desire to use even stronger. It's a vicious cycle.
And biologically in the brain, how does that hijacking happen?
Okay, first, there's a massive dopamine release. The substance floods the brain's reward center with dopamine, creating intense pleasure, that euphoria.
A feel-good chemical.
Right. Second, the brain makes a pleasurable recording. It learns super quickly to associate that intense pleasure with the substance, hardwiring the desire.
Like a really strong memory link.
A very strong one. Third, dopamine depletion and tolerance. With repeated use, the brain actually makes less natural dopamine and the receptors become less sensitive.
Ah, so you need more of the drug to get the same effect, or just to feel normal? That's tolerance.
Precisely. Fourth, the brain gets hijacked. The substance becomes the top priority, overriding everything else: family, work, health, values. It literally changes brain structure and function, especially in areas controlling impulses and decisions.
And finally,
Intense cravings and emotional lability. Overpowering desires for the substance, plus wild mood swings because of the dopamine roller coaster and chemical imbalances.
that cycle really shows why it's so hard to break free. It's not just willpower. Okay, let's clarify some terms. Addiction itself.
That's the mental and physical reliance, the compulsive use despite harm, often with relapse and remission.
Craving.
That intense physiological and psychological desire.
Tolerance we covered, needing more for the same effect.
And withdrawal.
Those are the nasty physical and psychological symptoms when someone stops or cuts down a substance they're dependent on.
Okay, so let's look at some common substances. Knowing the signs of overdose or withdrawal can be life-saving, right?
Absolutely critical. Let's start with alcohol. It's primarily a depressant, a sedative, even if it feels euphoric at first. We hear about binge drinking and heavy drinking. What are the definitions there?
Binge drinking is generally 5 or more drinks for men, 4 or more for women, in about 2 hours. Heavy drinking is more about weekly intake, 14 plus drinks a week for men, 7 plus for women.
And the legal limit, like 0.08 in Georgia, doesn't mean you're safe below that?
Not at all. Even small amounts impair judgment and coordination. Chronic heavy use can lead to severe things like Wernicke's encephalopathy that needs urgent vitamin B1 or Korsakoff syndrome, a memory disorder, plus major organ damage.
And there's a quick screening tool, CAGE.
Yes, the CAGE questionnaire. Cut down, annoyed by criticism, guilty feelings, eye-opener drink in the morning. 2 yes answers suggest a potential problem.
Good to know. What about opioids, like heroin, fentanyl, pain pills?
A key sign of overdose is pinpoint pupils, very constricted. The main danger is respiratory depression, breathing slows or stops.
And the antidote.
Narcan, naloxone. It can rapidly reverse that respiratory depression if given quickly. It saves lives.
Okay. Stimulants, meth, cocaine, Adderall.
Big risks there are cardiac seizures, heart attack, stroke. There's no specific reversal agent like Narcan. Treatment is supportive.
And sedatives, hypnotics, anxiolytics. Benzos like Xanax, Valium.
Their withdrawal can be incredibly dangerous. Seizures, tremors, even death. It needs careful medical management, often tapering the dose. Flumazenol can be used for benzodiazepine overdose.
Wow. And hallucinogens. LSD, mushrooms.
Risks there include panic, aggression, sometimes prolonged psychosis, maybe even permanent brain changes, plus things like high-potency cannabis today or dangerous inhalants.
It really highlights how varied the risks are. Okay, let's move into the very human side. Safety, intervention, and support.
Yes, protecting people in crisis and supporting those around them.
Starting with crisis management and safety, which often involves dealing with intense emotions like anger, aggression, and violence.
And it's key to remember, violence usually doesn't come out of nowhere. It's often the end point of rising tension. So early intervention is crucial.
What makes someone aggressive?
It's complex. Genetics, brain issues like injuries or chemical imbalances, even learned behaviors.
And in hospitals, where is violence most common?
High stress areas typically, emergency departments, psychiatric units, geriatric units sometimes due to confusion, and ICUs where patients can be very ill or delirious.
So what can be done? De-escalation is key, right?
Absolutely. It starts with noticing early signs: pacing, clenched fists, louder voice. Take all threats seriously. Intervene early.
Ow.
Use a calm, firm, respectful voice. Validate their feelings. I can see you're upset, but set clear limits. But hitting is not okay. Offering to walk and talk, move to a quiet room, or offering PRN or as-needed calming medication can really help.
And if that doesn't work?
As a last resort, maybe a show of force, having several staff present to show control or even force medication might be needed for safety.
And things like seclusion and restraints.
Those are the most restrictive options, only used as an absolute last resort, like if someone is actively assaulting staff or seriously hurting themselves, like banging their head. Patient safety is the #1 priority once they're applied, and the goal is to remove them as soon as safely possible.
Okay. Now another critical safety area. Suicide and non-suicidal self-injury, NSSI. They're different but related.
Yes, very important to distinguish.
So let's define terms. Suicidal ideation, SI.
That's thinking about killing oneself. It can range from fleeting thoughts to detailed plans.
Suicide attempt, SA.
Engaging in potentially self-harming behavior with the intent to die, whether or not death results.
And suicide is.
The intentional act resulting in death.
But non-suicidal self-injury, NSSI, is different.
Fundamentally, it's intentional self-harm, cutting, burning, hitting without the conscious intent to die. It's often a way to cope with intense emotional pain, feel something when numb, or punish oneself. The intent is different.
Got it. What are warning signs for suicide risk?
Some are intuitive, like talking about death or hopelessness, but one very concerning sign is a sudden switch from deep sadness to appearing unusually happy or calm.
That seems counterintuitive.
It can be. It might mean they've made a decision and feel relief. Another sign is giving away prized possessions or settling affairs.
And when assessing a plan, you look at lethality.
Yes. How likely is the method to cause death, and how quickly? A gunshot is generally much more lethal than taking pills, for example, because there's less time to intervene.
This brings up a sensitive point for listeners. How do you talk to someone you're worried about? Is it dangerous to ask about suicide?
That's a dangerous myth. Asking directly, compassionately, are you thinking about hurting yourself, or are you thinking about suicide, does not increase risk.
In
fact, it can reduce risk. It opens the door, shows you care, lets them talk.
And the myth that suicidal people hide it?
Most actually do give clues, verbal or behavioral. They might be subtle, but they're often cries for help. We have to listen. In hospitals, safety means removing potential, means plastic utensils, checking rooms for hazards, etc.
Okay. Let's pivot now to abuse and assault, focusing on vulnerable populations. This needs sensitivity.
Absolutely. And abuse takes many forms. There's neglect, failing to provide basic care, economic abuse controlling finances, and obvious physical abuse.
And some groups are more vulnerable.
Yes. The elderly, people with disabilities, the poor, pregnant women, and children, they often lack power or ways to escape or report.
And child abuse. The effects last a lifetime, don't they?
Devastatingly so. It can lead to chronic anxiety, depression, PTSD, substance use, and tragically, this deep belief that they're worthless, that they deserve it.
Which can feed into cycles later in life, like intimate partner violence, IPV, or domestic violence.
Exactly. IPV often follows a predictable, insidious cycle of abuse.
Can you walk us through that?
Sure. It usually starts with phase 1, tension building. Minor incidents, verbal jabs, control tactics. The victim feels anxious, tries to keep the peace. The abuser gets more irritable.
Then comes the explosion.
Phase 2, the acute violent incident, the actual assault, physical, emotional, sexual, maybe destroying things. The victim is terrified.
And after the violence.
Often phase 3, the honeymoon phase. The abuser is suddenly remorseful, apologetic, gives gifts, promises it'll never happen again. The victim, wanting it to stop, clings to hope.
And sometimes a calm phase.
Yes, phase 4, calm phase. Relative peace, which is misleading before the tension starts building all over again.
And this cycle just repeats.
Almost always. And usually the honeymoon phase gets shorter and the violence gets worse over time.
Why do victims stay? It's complex, isn't it?
Incredibly. Fear is huge. Fear for themselves, their kids, financial dependence, isolation, shame, and that heartbreaking hope that the abuser will really change.
Okay. Shifting to sexual assault, there are some really damaging myths out there.
There really are. Like the idea that rape is about sex.
Right. What's the truth?
The truth is, rape is primarily about aggression, anger, power, and control, not sexual desire.
And the myth about marital rape.
Totally false. Laws changed decades ago. Consent is required always, regardless of marriage. Spousal rape is absolutely recognized legally.
The effects of assault are profound.
Deeply. Depression, anxiety, low self-esteem, self-injury, sexual problems, even symptoms like psychosis or dissociation.
What's crucial in emergency care after an assault?
First, a safe, private, non-judgmental space. A trauma-informed approach is essential, prioritizing the victim's choices and well-being.
And care should involve a sane nurse.
Ideally, yes. A sane sexual assault nurse examiner. They're specially trained forensic nurses who provide compassionate care and collect evidence meticulously. Offering STD prevention and emergency contraception is standard.
And the most critical instruction.
Do not let the victim shower, bathe, or change clothes until after the sane exam. Preserving evidence is vital for potential legal action.
Good point. And related to safety, date rape drugs are a real danger.
Terrifyingly real. Key ones are GHB, Rohypnol, roofies, and ketamine.
What do?
They cause rapid sedation, maybe unconsciousness, and memory loss amnesia about the assault. The biggest immediate danger, especially mixed with alcohol, is respiratory depression, seizures, coma, even death.
So safety tips.
Protect your drink. Never leave it unattended. Use a buddy system. Simple things, but they matter.
Absolutely. Finally, in this section, human trafficking. Modern slavery.
Shockingly common and often hidden.
How is it defined?
Using force, fraud, or coercion to make someone perform commercial sex acts or labor against their will. And importantly, it doesn't require crossing borders. It happens everywhere.
Yeah, in Georgia, for instance, a child sex trafficking victim might just be a kid who got food or drugs or shelter in exchange for sex. Coercion isn't always obvious chains.
How are victims recruited?
Insidiously. Through family, fake job ads, online grooming, targeting vulnerable people, homeless youth, runaways, those with addiction issues, often in public places like malls or schools. The average age of entry is horrifyingly young, 12 to 14. And there's a grooming process.
Yes, a chilling process. Targeting the vulnerable, building trust falsely, isolating them from support, then abuse and control, using threats, and creating a trauma bond where the victim feels dependent on or even loyal to the trafficker.
What are the warning signs we should look for?
They can be behavioral, deferring to a companion, being withdrawn or anxious, seeming coached, maybe sexualized behavior for their age.
Physical sign?
Physical health. Delayed medical care, STDs, pregnancies, malnutrition, physical marks or branding tattoos.
Possessions?
Possessions appearance.
Wow.
Lots of cash or prepaid cards, expensive things that don't fit, inappropriate dress for weather or age.
Context.
Contextual, history of running away, lack of freedom, can't say where they live or work. These are huge red flags.
And if you suspect it.
Notify a supervisor or social services if you're in a professional setting. Call law enforcement otherwise. Don't confront the suspected trafficker yourself. It's dangerous.
Okay. This brings us to our final major section, interventions and the role of caregivers, healing and support.
Right, translating all this knowledge into action. How do we support recovery?
Starting with pharmacological approaches, medications that help balance brain chemistry. They aren't magic bullets, but they're vital tools.
Definitely. For bipolar disorder, lithium is still often the gold standard mood stabilizer, but it has a very narrow therapeutic window.
Meaning the dose has to be just right.
Exactly. The therapeutic range is usually 0.8 to 1.2 milli-UQL. Maintenance maybe 0.6 to 1.0. Too low, it doesn't work. Too high, it's toxic. Requires regular blood tests.
What causes toxicity?
Even simple things like getting dehydrated can raise lithium levels dangerously. Early signs are mild GI upset, maybe peeing a lot. Severe signs include tremors, confusion, seizures, coma, even death. It's contraindicated in pregnancy and severe kidney disease.
What other meds are used for bipolar?
Anticonvulsants like valproate, carbamazepine, lamotrigine are common mood stabilizers. They have their own risks, like serious rashes or liver issues, so monitoring is key. Lamotrigine especially needs careful watching for Stevens-Johnson syndrome. And second-gen antipsychotics are often used for acute mania to quickly calm things down.
Okay. And for depression?
SSRIs are usually first line, things like Lexapro, Prozac, Zoloft. They boost serotonin. SNRIs like Effexor or Cymbalta boost serotonin and norepinephrine.
What about older antidepressants?
TCAs like amitriptyline work but are dangerous in overdose. MAOIs like Nardil require strict diets to avoid a hypertensive crisis.
And the black box warning.
Crucial. For almost all antidepressants, there's an FDA warning about increased risk of suicidal thoughts and behaviors in people under 25, especially in the first few weeks or with dose changes.
Why that?
The thinking is the meds might boost energy before they lift mood, giving someone the energy to act on suicidal thoughts they couldn't act on before. Requires close watching. And related to serotonin meds, we need to mention serotonin syndrome.
With that.
A potentially life-threatening condition from too much serotonin, often from drug interactions like mixing SSRIs with certain other meds or even St. John's wort, can range from restlessness and confusion to high fever, muscle rigidity, seizures. It's a medical emergency.
Okay. Beyond pills, what other therapies are important?
Lots. Electroconvulsive therapy, ECT, despite its scary image, is actually the most effective treatment for severe treatment-resistant depression. Also used for severe bipolar mania.
How does it work?
It's a controlled electrical stimulation under anesthesia, causing a brief therapeutic seizure. It works quickly when needed. And talk therapies are huge. Cognitive behavioral therapy, CBT, helps change negative thought patterns and behaviors. For bipolar, interpersonal and social rhythm therapy helps regulate routines. Family-focused therapy improves family dynamics. Even things like omega-3 fatty acids show some promise for bipolar depression.
And tying this all together is often the essential role of the registered nurse. RN, they're critical, aren't they?
Absolutely central. RNs are often the primary point of contact. Their responsibilities are vast, recognizing signs of abuse, knowing emergency protocols, knowing resources.
Using those screening tools like CAGE, CIWA for alcohol withdrawal, CLWS for opiate withdrawal.
Exactly. Practicing therapeutic communication, active listening, empathy, and critically, being aware of their own biases about mental illness or addiction. Providing safe detox monitoring vitals, hydration, seizure precautions, offering emotional support, helping create relapse prevention plans.
Which leads to mandated reporting. Nurses has legal duties here.
They do. In Georgia, nurses must report any suspicion of child abuse within 24 hours. Suspicion is enough. Proof isn't needed. Same for suspected abuse of older adults or incompetent adults.
But it's different for IPV or sexual assault in competent adults.
Generally, yes. It's usually the patient's decision whether to report, respecting their autonomy. The main exceptions are if a deadly weapon was used or if the victim is under 17 or over 65.
And recording an impaired colleague.
If you suspect a nurse coworker is impaired, you report it to a supervisor, not confront them directly. Georgia's nursing board often focuses on rehab plans, treatment, drug tests, therapy, rather than just taking their license away immediately. It acknowledges addiction as a disease.
Finally, family interventions, supporting the whole system.
Crucial. Families provide management, communication, emotional support, socialization. Understanding family dynamics is key.
And the concept of boundaries.
Yes. Clear boundaries are healthy defined roles, respect, autonomy, connection. Diffuse boundaries are blurry, leading to enmeshment, lack of individuality. Rigid boundaries are too stiff, leading to isolation and distance. Therapy often works on improving these boundaries.
And we mentioned the SANE nurse earlier, a perfect example of specialized intervention supporting both the individual and potentially their family after trauma.
Exactly. They provide that holistic care, medical, forensic, emotional support, referrals.
So what does this all mean? It means understanding mental health is a deep, ongoing journey. We've covered so much ground today.
From the nuances of mood disorders like bipolar and depression.
The profound impact of trauma, the complexities of addiction.
And importantly, the compassionate, evidence-based ways we can intervene and support people.
Yeah. So what does this all mean? It means understanding mental health is a deep, ongoing journey.
It truly is. And the key takeaway is that this knowledge is powerful. It builds empathy, it chips away at stigma, and it equips you, listening, to maybe spot warning signs, advocate for yourself or someone else.
Absolutely. Which leads us to a final thought for you to mull over. Given how common and complex these conditions are, how can we as individuals, as communities, better weave mental health education and support into the fabric of our everyday lives? How do we move beyond just awareness to truly proactive, compassionate care?
Thank you for joining us for another deep dive into these really essential insights.